Thank you. I'm just going to give you a brief overview on my experience with trifocals. I've been implanting trifocals over the past 3.5 years, and I still consider that's my preferred IOL of choice at the moment. So this is my experience with the trifocals. The Physiol, which I started, unfortunately is no longer available in India. We are hoping it will be available soon. The 80 LISA trifocal from Zeiss, then the Indian triphobic, and I compared it with the Symphony, the EDOF lens. So there are different types of technology which is available in the trifocal. As you all might be aware of the apodized diffractive IOL, the Alcon Resto, which was launched way back in 2008. It is a multifocal. Then we had the Physiol, which is the first trifocal, which is a diffractive apodized lens, which is pupil dependent. Then we have the non-pupil dependent, the trifocal non-diffractive non-apodized lens, which is the 80 LISA tri. Then the non-apodized Panoptics from Alcon, which is a trifocal diffractive lens. Then we have our very own Indian patent on this trifocal called triphobic, where we have an increased angulation and decreasing height from the periphery to the center. From the center to the periphery, here you can see there is angulation is also decreased compared to the apodization in the other trifocals. So brief overview of the different types. The Physiol is a convoluted trifocal, whereas the 80 LISA tri is a diffractive trifocal, and the triphobic is a diffractive trifocal. The EDOF lens, the Symphony, which I did study, was an Eshelett design. And you could see the light distribution. Most of them contribute around 50% of the light is split for distance and 15% for near. And the intermediate and near is around 30 to 45% for the rest. Here you see the Physiol is the only lens trifocal which is pupil dependent, whereas the other lenses are pupil independent. What's more important, I like to point your attention towards the end of the slide, where the spherical aberration, which is very crucial because you need to center these lenses directly on the visual axis. I'll be talking about angle kappa and centration and angle alpha as well later, as Dr. Shweta pointed out. These lenses are negative aspheric lens. So it's imperative we position them exactly at the visual axis with very less margin of error. So I did a small study where I've done more than 150 trifocal implants till date, but we included around 50 eyes where we had a follow-up of 1.5 years in these patients. We all implanted them bilaterally with either a trifocal or a small set of patients who 11 eyes who underwent Symphony or the EDOF lens implant. So we compared their visual acuity outcome, the contrast sensitivity, the near and intermediate at 1 month, 3 months, 6 months, and 1 year. So all these patients underwent uneventful bilateral cataract surgery by the same surgeon. We used different formulas, the universal Barrett's 2 online calculator, to find out the accurate IOL power was decided close to the emmetropic value. All the patients underwent surgery under topical anesthesia. We did a exhaustive preoperative workup. Spectral luminosity of macula for all these patients was mandatory. And we did measure the angle kappa of all these patients with the Scheimpflug tomographer preoperatively. They also underwent dry evaluation and a mammogram. Those who had very poor tear film breakup time or maybe some form of meibomian gland dysfunction were not the ideal candidates for these premium intraocular lenses. They've been asked to go for a monofocal counsel for a monofocal lens. Topography was mandated in those patients who had an astigmatism more than 1 diopter cylinder or 1. We had a cutoff of 1.25 diopter cylinder for toric trifocals. Those who had 1 diopter of cylinder and less on topography were taken up. We were also able to measure the chord or the mu value in these patients. Those who had a chord value of less than 0.6 were taken up for trifocal implantation. So we analyzed around 50 eyes. In that 11 patients were male and 14 were female. The visual acuity was recorded at 1 month, 1 week, 1 month, 3 months, and 6 months post-operatively. The distance visual acuity is recorded with visual in a mesopic condition. Intermediate chart, we used the Colin-Brander chart logmar scale, and they were also shown subject to perception of glare and halo with the halometer with the images shown online. So if you take the distance visual acuity, Immediate post-op at 1 week, they were all at 6.9 or 6.12, and they improved to 6 by 6 parts or 6 by 7.5 at end of 1 month. It was similar for all the three lenses. Once they implanted bilaterally, the triphobic did do well. The intermediate vision chart, we used a modified Colin-Brandner chart where we had the high contrast and the low contrast side by side, and we asked them to read them in ambient lighting. In clinic testing never translates to the kind of vision they have at their particular home or their office, because we use more amount of ambient light. So we always tell the patient, these lenses some lenses of trifocals are pupil dependent, so you need to read in bright lights. So near vision was tested at 63 centimeters and 40 centimeters with the Colin-Brandner chart. And here again, we find that these patients who had bilateral implantation of trifocals did far better than the EDOF lenses. In EDOF lenses, initially we were implanting bang on emetropic target, then we went ahead and did a micromonovation on the fellow eye once we're not able to see J1 or N6 in the near Snellen chart. And they did better once you had bilateral EDOF with micromonovation, and other eye corrected slightly myopic at -0.5. The Logmar intermediate visual acuity chart again showed more in favor of the trifocals. Here you could see the Physiol did really extremely well with intermediate vision. They were J1 or N6 right from day one. The AT Lisa also did equally well. The EDOF lens Symphony, however, did catch up once we did bilateral implantation end of 6 months. The triphobic, the Indian intraocular trifocal lens, did also reasonably well. Once they got it implanted bilaterally, they were doing much better. So this was the defocus curve, and there are different types of lens. We prefer the cast molded lenses because they have lesser imperfections. It's mandatory to always see these lenses under the microscope, under high mag, and I always prefer to load them myself rather than an assisting scrub nurse to load, because sometimes you might end up with these marks on these lenses, these trifocals, which might damage these central rings. The contrast sensitivity distribution in the trifocal, again, as you could see in different pupil size, the maximum amount of visual acuity was seen in a smaller pupil at 3 mm. Though they marketed as pupil independent, the energy transmission is more in the 5 mm, whereas the contrast sensitivity is much less when the pupil slices are longer once you dilate them. So we, at mucipic conditions around 4 mm, we are able to achieve better visual acuity and better energy distribution with regard to the contrast sensitivity. Moving on to angle kappa, why I would like to say it's very important when you're planning your surgery, because this angle kappa is the angle between the visual axis and the pupillary axis. It is measured in a 2D plane called mu or a chord. It can be done in any Scheenflug topographer, a pentagram, or it can also be done on IOL Master 700. This angle kappa is very important because we are going to center our trifocal ring, the central ring, which is around 1.2 to 1.5 millimeter over this central, when you ask the patient to foveate when we are doing the surgery. And this angle kappa makes an integral difference when you have post-operative reduced visual acuity, when that you have this capsular bag contraction in some of these patients who are hyperopic, then you have this slight decentration of the central ring away from the visual axis, then they don't have adequate visual acuity for distance when you have a suboptimal outcome in these patients. So this is a slide which shows that we are using all negative spherical IOLs. Once they are slightly decentered by 5 mm, you can see in the bottom left how much of distortion they experience. And once they're decentered by 1 mm, and the entire ring, the central ring, which is around 1.2 mm, goes off the visual axis, they might read 6/9, but the quality of vision is definitely compromised. So it's imperative we look at angle kappa in all these patients. This is a video which I'll just show about how I plan my rexes centered on the visual axis. I prefer doing all the patients under topical anesthesia. We ask them to foveate at the center. We look preoperatively at the angle kappa, and once the patient is asked to foveate the coaxial illumination coming from the microscope, we center the rexus. First, I center the rexus based on the first Purkinje image. Once I'll just scrub this forward for want of time. Once the rexus is done, I load the lens myself, inspecting it clearly. This is a trifocal implant which is being loaded and implanted here in the bag. We ask the patient, once they implanted in the bag, we try to center it between the optical axis and the visual axis. It's important to know, and in my experience, I feel that even during postoperatively after 1 month, even if we center it along the pupillary or the visual axis, in the end, the patient eventually IOL orients towards the optical center, which is the limbus. The postoperative analysis of the patient, here you could see, which is the diameter of the limbus. The center of the limbus is the optical center, and the center is the pupil center. So difference between this is the angle alpha. The pupil size is again a quantitative indeterminant here because different types of pupil dilatation is achieved. So there might be a slight shift in angle kappa, but I still like to definitely center my lenses along the visual axis. But eventually over a period of 1 month or 3 months, you see these trifocals will shift over to the optical axis, which is again based on the limbus. So these are the trifocals which I have implanted, and the triphobic and the AT-LISA tri. Here you could see these lenses comfortably pass through a 2.2 millimeter incision, except the Physiol trifocal, which requires slight extension to 2.8 mm. Since the optic is larger, which is 6.25 mm, it's a plate, it's a quadrupod, can easily be nudged into the bag. A Zeiss AT-LISA trifocal is a hydrophilic material with a hydrophobic coating. We did encounter significant amounts of PCO in these patients in spite of complete washing post-operatively of the residual visco. So we do take a slit lamp pictures at the end of 3 months and 6 months, looking for any visual axis orient disturbance due to PCO. This one patient who had a perfect rexus in the bag IOL, but after 3 months, we see this patient had some amount of decentration in this Zeiss AT-LISA tri. The axis is shifted slightly superiorly due to capsular bag contraction. She was a hyperope. Then we realized that we should have aimed for a much larger rexus than what was planned. So when you aim for a rexus of around 4.5 to 5, I would still expect it to go to 5.5 when you have these plate-actic lenses implanted, so that if you are having a capsular bag contraction also, it doesn't decenter later in the post-operative period. There's another video, for want of time, I'll share it later. To conclude, a trifocal lens provides a good range of vision when implanted binocularly. The Zeiss AT-LISA trifocal gives the best good near and intermediate vision. There is subjective photic phenomenon in these lenses. Triphobic had the maximum, followed by Physiol, then followed by AT-LISA trifocal, then the Symphony. The PCO rates were more with AT-LISA trifocal, where 2 out of 10 eyes required YAG capsulectomy at 3 months. The near and intermediate vision were equal with Zeiss AT-LISA and Physiol compared with Accredit for the triphobic. The Symphony didn't fare well with near vision. We had to go with micro monovision, then they did binocularly better. So always remember, we do always under-promise but over-deliver in our surgical outcomes to get the best outcomes in your patients when you implant these premium lenses. Thank you for your kind attention.